Attends. Non, non, attends, je lance.
Okay. I will admit everyone now.
Hello, everyone. Welcome to today's postgraduate course, Achieving Equity in Action, Designing and Implementing the ECHO Virtual Community of Practice Model to Strengthen TB Workforce Capacity. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone has been muted to avoid background noise. We encourage you to turn your webcam on throughout the session if you can. Can we please ask you to change your display name to your name and country? Click on Participants on the bottom menu bar, hover the mouse over your name, click on More, click on Rename, enter your name and country on the screen name field, and click the OK button. You will have the opportunity to submit text questions and comments to today's presenters by typing your questions into the chat. You can send questions via the chat at any time during the session. The moderators will collect them and address them after the speaker's presentation in the allocated Q&A sections. You will have the opportunity to intervene in today's session by submitting a request to do so via the chat or by raising your hand. The moderators will record your request and inform you when you can intervene. They will have the opportunity to provide feedback in the end of a session evaluation survey, which will appear directly in your browser once the meeting closes. And it's important that you complete the survey right after the workshop, as the link will only be available for a very short period of time. You will receive a certificate based on your attendance and the completion of the evaluation survey. Please note that this session is being recorded and the recording will be available to the public a few days after the session. Finally, it is my pleasure to inform you that today's chairs are Diana Fortune and Nita Singla. Over to you, Nita and Diana.
Thank you. Good morning to everyone. Good afternoon, good evening, depending on which time zone you are in. Nita and I are very happy today to be facilitating this session. And as was said earlier, it is the ECHO postgraduate course on achieving equity in action, designing and implementing the ECHO virtual community of practice model to strengthen TB workforce capacity. So we have a variety of speakers today that are going to share their experiences with the ECHO model. And then about the last hour of the postgrad course, we're going to walk you through a strategic planning workshop so that you can get a feel for how it would be if you wanted to start an ECHO program within your community. And I'm going to do a quick screen share so that you can see the folks that we have on the agenda today. And I said I wasn't going to do this, and see, and I can be the first person to mess up the screen sharing, so nobody else has to feel bad about it not working.
It's working.
Okay, so here we go. So we have 5 speakers that are going to be presenting today, and we have a speaker from India, from Armenia, from the United States, Indian Health Services, another speaker from the United States, from the Northeast, and then a speaker also from Tanzania. So we have, you know, a very broad representation of ECHO programs from across the world to share their experiences. So I know everyone will be very interested in hearing all of those. So I just wanted to do a very brief overview of that for you. So let me stop my screen share. And the next thing that we wanted to do, just to give everybody a feel for utilizing the polling, is I think Amy's going to bring up, yes, so there it is in the chat. If everybody would just go ahead and click on the link that's in the chat button, it should bring up a map of the world. So you can drop a little pin drop into where you are participating from today. from around the world, and we can see visually where everybody is. So I'll give everybody just a couple of minutes to do that. I always enjoy this part, seeing where everybody is from. So
yeah, hi everyone. Dinah, maybe you can tell them the importance of the incognito that we have on the screen on the right side.
The importance of what?
Yeah, the importance of we are not taking any names or recording any names.
Yes, yes, thank you very much. Yes, as we do the polling exercises today, please feel free to share your honest opinions, because all the polling is anonymous. So none of the poll results will be linked back to any individual. So please feel free to share at liberty that way. So we won't know who it is that's sharing. Okay, I still see a few pin drops, but it looks like they're about finished. So this is terrific. Looks like we've got about 60 people on so far, and we may have some others join later. So Nita, I'm going to go ahead and pass it over to you, because I think you are going to do the next part of the introduction.
Yeah, thank you, Diana. And I'm Nita here from India. And I'm going to tell you something about the worksheet that we are going to work on, the strategic planning worksheet. And one of the objectives of our workshop is to give you a deeper knowledge of how to plan and echo, how to implement, or how to expand if you're already running a program. So we have made a worksheet. We are going to work on it at the end of the session, and you have it on your chat. The link is there. You can see the worksheet if you want. And we are going to fill this worksheet at the end of the session, and then we'll have a discussion on the thing. So I would request you to listen to all the talks that we are going to have, because they are going to help you to fill this worksheet. Thank you. Over to you, Diana.
Okay, so without further ado, we are going to go ahead and get started with our first speaker. And I think our first speaker, everybody knows very well. It's Dr. Bruce Strumminger, and he's the Senior Associate Director of the Echo Institute for the University of New Mexico in USA. And if you would like to see a more detailed bio on Bruce, it is pasted into the chat that you can look and see some more information about him. And Bruce, I'm going to hand it over to you.
Thanks, Diana and Nita, and thanks to the union for the opportunity for us to conduct this postgraduate course. And thanks especially to all the participants for joining from around the world today. It's really a pleasure on behalf of the Echo Institute at the University of New Mexico in the Southwest of the United States to share a brief overview of what Project Echo is, and some of the expansion of the TB Echo work over the last 7 or 8 years. The title of my talk is Developing Echo Virtual Communities of Practice to Strengthen TB Prevention, MDR-TB, TB-HIV, and TB Program Leadership and Management. And the key phrase here is virtual communities of practice. Echo is an education and workforce development initiative that started at the University of New Mexico almost 20 years ago, and to provide continuous education to practicing clinicians, doctors, nurses, pharmacists, laboratorians, et cetera. Just to mention, I have no conflicts of interest to report. Just sharing a screenshot here of the first TB Echo program, which started back in February 2015. That was in Vietnam. And that program continues to today. It's in its 6th year, going on 7 years. In Kenya, the first TB Echo started in 2016. So it's also 5 years old and been running weekly for MDR-TB, expanded to pediatric TB, and also they have a TB Data for Action program. You're going to hear more from Upasana Agarwal a little later about the India National Institute of TB and Respiratory Disease TB Echo programs. They have I think more than 5 different programs they're supporting out of the National Institute. They started just over 5 years. Their 5-year anniversary was last month, which is totally amazing. And Nita Singla also supports that program and others related to it. So many of these communities of practice have been running for many years and expanding geographically and programmatically. Our mission at Project ECHO is to democratize medical knowledge and dramatically improve access to best practice care for underserved people all over the world. The equity issue that's a theme of this year's Union Conference is core to the ECHO mission, because really ECHO is all about increasing access to education for clinicians. So that's an equity issue, and that's so that patients can have access to better high quality care right where they live. So the idea is to move knowledge, not people. So the ECHO model, very simple, 4 components. First being to use the same technology we're using today, though it could be a different type of video conferencing platform. And that's to amplify the scarce human resources of specialists who might be at the hub and with participants in local TB clinics or local laboratories, et cetera. Also, these programs are all run by local leaders. And the idea is these ECHO programs empower local experts and practitioners to amplify their voices and their ability to teach colleagues across countries and multiple countries. It's a case-based learning methodology. To me, that's the most important thing, that participants present real patient cases or system cases, quality improvement cases. I mentioned there's a TB data for Action ECHO in Kenya, so they could be data cases, et cetera. It's a guided practice telementoring approach. The third principle is sharing best practices. Most ECHO programs have a brief didactic to reinforce evidence-based guidelines, all with the goal of improving outcomes by reducing variations in processes of care. Usually those didactics are 15 or 20 minutes long, so that most of the session, that might be an hour and a half, is discussion of cases. And then the fourth element is monitoring and evaluating outcomes to promote continuous quality improvement. And there's a wide variety of evaluation approaches that have been taken for different ECHO programs, and we'll probably talk a little more about that later, and our presenters may speak about some of the examples of evaluations they've done. People often ask, how is ECHO different from a webinar? The technology is very similar, but the design is very different. As I said, ECHO is about ongoing learning communities and creating continuous communities of practice. They're about very interactive learning and experiential learning where the participants are very engaged. It's an all teach, all learn model. The diagram here is trying to illustrate how knowledge and information flows in an ECHO session in all directions. This is just highlighting some of the adult education principles. We try to promote experiential learning, problem-centered learning, case-based learning, a very interactive approach to learning. It's a great opportunity, these ECHO communities, to build bridges across ministries of health with academic medical centers, the public sector, the private sector. You can invite anyone to your learning party. And that's also true about taking an interprofessional approach to involve all the members of the healthcare team that are involved in your topic. Doctors, nurses, laboratorians, community health workers, epidemiologists, pharmacists, everyone who's part of the team that's providing care ideally is represented both at the hub, it's a hub and spoke model, at the hub expert level and at the spoke participant level. This is just summarizing why ECHO works, some of the things I've already mentioned. It's really important that these be need-based and The ECHO programs are designed ideally in participation with participants to make sure you're going to meet their needs, taking a human-centered design approach, but incorporating these components of case-based learning, experiential learning, collaborative learning. As I mentioned, it's a low-dose, high-frequency learning approach. There's good evidence for that. The peer-to-peer learning we often hear is super important to participants. We really try to promote a non-hierarchical approach, and these are social professional networks that ideally are fun, that you're getting together with your colleagues to learn together, and their quality improvement is implicit, and often we're seeing explicit QI integrated. In the US, there are over 250 partners implementing programs across the US in 48 states around the world. There are almost 500 partners implementing programs, nearly 1,000 programs in over 50 countries. This is just highlighting where many of the TB ECHO programs are. We're actually missing Kazakhstan, and Kyrgyzstan should be lit up there. They have TB ECHO programs as well. And the ECHO, TB ECHO community has expanded every year, and we're hoping that many of you today who join us will want to create your own programs. And you're going to get a deep introduction today on how to do that. And then ideally, you may come back and become an ECHO partner and attend the 3-day immersion. Some programs use asynchronous communication like Slack and WhatsApp to engage participants outside the live sessions. We also have a quarterly TB Meta ECHO learning collaborative that's been on pause for the last year and a half during COVID, but we're hoping to restart it early in 2022. And that's for the leaders of programs to get together and share experience and resources, et cetera. This is my last slide, which is just outlining the next steps to joining the ECHO movement. There's a simple partnership process. There's no cost to being an ECHO partner, but there is a little paperwork. You then attend a 3-day immersion training. Now we're offering those virtually. There's no cost for those. And then you design your ECHO program and you implement it. And we mentor our partners as they're doing that. So again, thank you very much, Diana and Nita. I think now, I don't know if we have any time for a question or two, but we do have a few polls that we're wanting to get a little feedback from all of you about the basic principles of the ECHO program. So if everyone could respond to these, we'll take a few minutes while you're responding. And this is just to give us a sense of whether we communicated well to you. You should be able to answer these on the Zoom polling. And if anyone, and Diana, give me a time check. How are we doing?
We're working on the 5-minute Q&A part of it, and there weren't any questions in the chat. So I think doing the poll might be a
Okay,
perfect
excellent.
way to.
If anyone does have a question, feel free to put it in the chat or raise your hand, and we're happy to have you ask the question verbally. And we've got about 25% of participants have responded to the poll. We'd love to get 50% before we move on. Got 42%. Thanks. One more person answers, we'll go over 50%. There we are. Okay, Carolyn, can you please share the results? Excellent. So the first question was ECHO virtual communities of practice, strengthen health equity, help democratize knowledge, build professional learning communities, promote peer-to-peer learning. all of the above, and 86% said all of the above, and that's correct. So well done there. The second question was Echo virtual communities of practice leverage video conference technology to bridge geography and empower the agency of local experts, highlight case-based learning as a core learning methodology, promote sharing evidence-based best practices, include some monitoring and evaluation to inform program quality improvement, all of the above. And yes, again, it was E, the right answer, all of the above, and nearly 80% responded accurately there. The third question was Echo virtual communities of practice are essentially just like webinars. No one said yes to that. So everyone gets a gold star, well done. B is our low dose, high frequency learning approach, promote interprofessional learning, promote collaborative learning, promote non-hierarchical learning. Well, anyone who answered yes to those are correct for sure. The answer was G because A are essentially just like webinars was not correct, but everyone did well. Thanks for participating in those polls. That was a warm up. There'll be more polls to come in association with our other presentations. So we can take the polling down. And were there any questions?
No questions in the chat yet. So there was one comment, certainly Echo has changed the dimension of learning, just some reflection on post-learning follow-up.
And I don't know if Shashikant is able to, Shashikant, do you want to say something about what you mean by what reflection you'd like about post-learning follow-up? Just wanting to make sure I understand the question. Any of my collaborators feeling like, how do we address post-learning feedback? Oh, good point. So most Echo programs have an anonymous survey at the end of each session for post-session feedback. And that feedback goes to the program managers of the Echo programs for them to review. And that's an opportunity for them to take that feedback and make corrections and improvements in their program and to focus on topics that the learning community prioritizes. So that's one of the key principles we try to promote is both collection of that feedback and use of the feedback for program improvement. Many programs after 6 months or a year will do more elaborate evaluations of different kinds. And that feedback, again, is reviewed and hopefully each program is taking that feedback into account and redesigning and improving their programs based on it. And I don't know if any of my colleagues want to make any comment about that evaluation and how you use feedback from your post-session evaluation and other evaluation to improve your programs. I think what I'll just say is our presenters for different Echo programs give their presentations. I think most are going to make a few comments about how they use post-session and midpoint evaluation feedback to improve their programs. Thanks for that question.
Okay, I think
Great.
that about
Thanks, Diana.
covered the 5 minutes. Yeah, so very good. Perfect timing for our first presentation. So Nita, I will pass the baton to you to introduce our next speaker.
Yeah, thank you, Diana. And now I'm going to introduce Dr. Upasana. She's my colleague and she's an internal medicine specialist. And of the 8 programs, the ECHO programs that NITRD runs, she's running a very important clinic on HIV and TB. So Upasana, over to you, and you can read more about her in the chat. There is all about her in the chat section. Upasna, you're muted.
You're mute.
Am I audible now?
Yes.
Yeah. So good evening, good evening. I'm Dr. Upasna. I work at the National Institute of TB and Respiratory Diseases in New Delhi, India. And what I'll tell you over the next few minutes is a story. It's a story of how we began with a small clinic with less folks and how we kept on expanding step by step by step. And the expansion was not only conceptual, like there were different concepts of TB that we kept on adding on. It was also more in number of spokes, number of the type of participants and the type of healthcare worker that we kept on including in our clinics. So this is a story of ECHO. And the topic for me is nationwide expansion of the Delhi MDR TB ECHO program to support TB elimination and capacity building of HIV physicians to treat TB with ECHO support. I have no conflicts of interest to report. Well, just to begin the talk, some background information. What do we actually mean when we say TB elimination in our topic? TB elimination basically refers to this WHO NTB strategy in which WHO expects, like it is working towards a target of globally reducing TB deaths by 95%, cutting new TB cases by 90%, and bringing down catastrophic expenses due to TB to 0%. And when we talk of elimination of TB, why India? Why should ECHO have come to India? Why should there be TB echoes in India? If you will look at the right-hand corner, this orange box, you will see that we in India have 27% of the global burden of TB. And we also had 27% of the global burden of MDR TB. And unfortunately, we have the dubious distinction of having the maximum TB burden in the world. So of course, if we talk of elimination of TB in the world, we do need to talk of measures and steps taken in India. Now, just another minute on the pillars and components if we now move on to the left side box. So if we want to eliminate TB or we want to follow the WHO NTB strategy, it has 3 pillars. And if you would look at the first pillar, which we would expect to be very, very important, the 2 components of the first pillar, basically integrated patient-centric care and prevention, mentions early diagnosis of TB, screening of TB, and correct treatment of TB, as well as drug-resistant TB. And if we come to the pillar 3, there is a component which says discovery, development, and rapid uptake of new tools, interventions, and strategies. So the WHO recognizes that unless and until we come up with innovative ideas, newer ideas in the field of research, training, teaching, treatment management, we are not looking at TB elimination. So with this background, I would just like to again say that, okay, so why telementoring? ECHO is a telementoring platform. And it is a package. It's a package of how you do an ideal telementoring in which, as Dr. Bruce said, you move knowledge, but not the patient. And in a country the size of India, it is impossible to cover all your healthcare workers in the routine manner, in offline classes, in offline trainings. So a telementoring ECHO clinic is the most cost-effective intervention for knowledge dissemination in high burden and high population countries like India, where it can be used for capacity building of all kinds of healthcare workers, which would definitely lead to early diagnosis, treatment, and management of TB. You can reach a large number of healthcare workers in a single session, which is just not possible in an offline class. And the most interesting thing is that you can effectively disseminate knowledge to the periphery. In countries like India, there's a huge peripheral primary health network, which are usually left out in the offline trainings and teaching modalities. So this telementoring with a minimal of equipment and a packaged way of doing telementoring is actually very effective in reaching our primary health centers and peripheral workers who happen to be the backbone of our TB control program, and without involvement of whom we cannot be thinking of any TB elimination in our country or in the world. Some reason the slide is not moving. Yeah. So this, I think, is why, and now coming to our first TB echo clinic. So beginning the story, I think somewhere in 2016, we had a visit from a team from Echo India and Echo Institute, New Mexico. And they actually introduced us to this idea of echo clinics, the package on how there's a hub, there's a spoke, how the hub is trained, how the spoke is trained, and how you can pick up topics and help all your community. It would be peer learning, it would be each one teaching one, and it would be actually connecting with people who are involved in TB and in the TB world. So when we assessed the need for a TB echo, there was no doubt about it. Of course, we needed a TB echo. Of course, we needed a TB mentoring platform in our country. But we felt that DRTB should be the first subject that we should pick up, because there were lots of changes that were taking place in DRTB treatment and diagnosis. And to begin with, we felt confident in being a hub, being a tertiary care TB institute, but we were not very confident as to what should be our spoke. So we made a small beginning. We began with the Delhi state field offices known as the district TB centers, which were actually managing all drug-resistant TB cases which were being treated programmatically. So we began with 25 spokes. After that, there was an immersion training of the teams, both hubs and the spokes. We came back, and then we started designing a curriculum. The essential part we understood was that it has to be broad-based. We cannot compartmentalize topics too much in an echo clinic, because then some people are left out. It becomes very, very repetitive, and you have actually not covered all the aspects. So we tried to make a broad-based curriculum, which would include diagnostics, treatment, adverse drug reactions, newer drugs, guideline updates, field issues, adherence tools, etc., etc., etc. We identified the experts. We prepared a case discussion form, did a trial run, and then finally, in November 2016, we started our first Delhi State DRTB clinic. We were the hub, and the 25 district TB officers were the spokes, plus the state TB officer. And this clinic was involving chest physicians, public health physicians, TB coordinators, microbiologists, and other kinds of workers like the lab technicians. And we went ahead with this clinic. Sorry. So this is how our clinic looked like. This is us at the hub, the panel at the hub. And this is one of our district TB officers who was presenting a case. And if you would look at the screen, initially we used to have about 25 to 27 people logging in. That used to be the sum total of our spokes. But we actually were gaining experience session to session. We were becoming stronger. And once we only few months down the line doing this clinic, we realized that there were certain other centers also which had the capacity to be a hub. After we had started being a hub, there were other centers who felt they could also do it. And so we went on a concept of rotational hub, and we rotated the hub activity between New Delhi TB Center, RBI TB Center, and AIMS, while we call ourselves NITRD. NITRD also remained as the fourth hub. So we expanded the hubs, plus we expanded the spokes. This all occurred just a few months after starting the clinic. We expanded to Gujarat, Maharashtra, Assam, and Tamil Nadu. So these were 4 other provinces or states of India other than Delhi. So this is how expansion took place initially within the clinic itself. And now the clinic has been into more than 3 years of operation, and 124 sessions have taken place, and 14,508 man-hours of training has already been done by this clinic. But to say something very important about this clinic was our first clinic, and it taught us a lot. It taught us how to run and have a sustainable eco clinic. We learned that regularity of sessions was very important. We had to maintain high quality of sessions. If the participants did not feel that these sessions were adding any value to them, they would eventually lose interest. We had to encourage mutual discussion. We had to take regular feedbacks from spokes, and we actually realized that internet connectivity was very, very important. however interested you might be, the hub might be, all the schools might be, but if you keep on having internet breakdowns, then these sessions are not going to work. So in a country like ours, we learn to have one main internet line, then a backup for a backup. So we realized that internet connectivity was also very important. And while we were learning these lessons from our DRTB ECHO, in 2016, there was also a major change in management of HIV-TB in the National AIDS Control Program. Like HIV-TB is managed primarily by another program known as the National AIDS Control Program. And they totally shifted TB treatment of people living with HIV, which was earlier being done by the National TB Program, to the HIV clinics. A 2-day offline training was given to all HIV teams throughout the country, but the next year, like 2017, demonstrated that this training was highly inadequate. And we could see our HIV teams going teetering around the TB concept. Somebody would not know what drugs to give. Somebody would not understand what is the weight band. Somebody would not understand what is daily dots and how to manage it in an HIV center. So there were basic numerous questions. And taking these into consideration, we realized that we had the option of mentoring people in HIV-TB. Also, we had the expertise for that. And so with that expertise, we went to both the national programs, we went to the Central TB Division, we went to the National AIDS Control Organization, and we requested them to give us permission to start a HIV-TB ECHO. We got those permissions, CDC came on board, they gave us logistic support, Share India gave us the technical support, and ECHO Institute was always there to help with whatever we needed for this program. Again, NITRT was the hub. 2018, we began this clinic. We began with 4 states, 2 states in the north, 2 states in the south. And the northern states, the primary language used was Hindi. And in the southern states, the primary language used was English, because in India, you change the language every 100 kilometers, you change the language. So we had to make 2 separate sets of spokes. 2021, we expanded to 9 more states. And now we have somewhere like 155 HIV clinics in our HIV-TB ECHO. This is how an HIV-TB ECHO looks like. And you can see that our session board is very crowded in this particular clinic. Initially, we felt that this would be a deterrent for good discussion. But actually, interestingly, we found this clinic to be very interactive. There has been a lot of discussion, and we have not found about having 150 participants every clinic to be a problem. Interesting thing of HIV care in India is that it's a team approach. So there'll be a doctor, there'll be a nurse, there'll be a counselor, there'll be a pharmacist, there'll be a field worker. And the team that sits for the ECHO clinic is a very diverse team, but they all speak the language of HIV. So it is so we have to find a balance between going high tech in expertise and also to keep in touch with our field issues. So over the past 3 years, we have done 79 sessions and 45 cases have been discussed. And while in 2018, we launched the HIV-TB clinic, our institute realized that if we have to think about elimination or good control of TB, we have to start involving every kind of practitioner in the country, every kind of TB practitioner. We realized a lot of TB, especially in the provinces, is being done by our university hospitals. And the university hospitals have beautifully trained people. People have a lot of knowledge. They are very intelligent. They see a lot of cases. But there was some niche, some definite information about TB that was probably missing for them in their curriculum or in their training because they were more broad-based. They would do internal medicine and they would do all tropical diseases. They were not actually totally focused on TB. So there were certain places where we felt as a tertiary TB institute, we could contribute to the learning and ultimately help in TB elimination. So in 2019, we expanded to university hospitals, and we also expanded in 2019 to peripheral health workers. These girls in pink whom you can see, these are our peripheral health workers. These are called ASHA workers. These are from villages. One ASHA worker is responsible for about 2-3 villages. So we started training them. And finally, the first clinic that we had started, it had already run more than 3 years, and they started feeling that now they were well trained, and now TB training had to move to people other than the district TB officers. And so this clinic metamorphosized into a difficult to treat TB clinic, which went national. They went national, and all kinds of TB practitioners were brought on board, the private practitioners, the university colleges, the peripheral health workers, people in government hospitals, people in non-government hospitals, everybody was brought on board. They have already done 6,000 man-hours of training. And this is the natural history of progress. I would say the natural history of a TB echo in our institute. We first had DRTB, then TB HIV, then for university hospitals, then for peripheral health workers, and then the metamorphosis into a difficult to treat DRTB, which went national. And I'm happy to announce that we now have a TB thoracic surgery echo also started in 2021. This is how the map of India looks, with all the oranges being the hubs of echo. And the last slide, the way ahead. The way ahead for us is to keep on expanding, more spokes, more HIV clinics, more states. We are only in 13 states. We want to go all 28 states. And while we keep on including people, we have to make certain earlier spokes self-sufficient by creating regional hubs. We envisage ECHO to be an inherent training modality of the national disease control programs, and even probably medical curriculum, because we have seen amazing results with this modality. And we need to keep on identifying new and new areas of unmet training needs and initiate and sustain further TB echo clinics, like in mycobacteriology, TB radiology, respiratory critical care, antibiotic stewardship. And with that, I'd end my talk. Thank you. So this is the story of TB echo in our institute.
Thank you, Upasna. Can you stop sharing the screen? Yeah, thank you, Upasna. That was indeed a very nice talk. Please post your questions on the chat so we can ask Dr. Upasna. Meanwhile, Dr. Upasna, we have two questions from our registration form which they were asking. How to engage participants and make sure that they really engage in a long distance learning? How did you engage them?
Yeah. So this is the biggest challenge that we always have, and it continues to be a challenge. And there's no one single answer. So mostly what we do is that when we see when we see people on the screen, we come to know that some are engaging and some are not engaging. And we usually try to draw them out by being on a first name basis. Like I would just say, for example, I would say, Nita, please, would you like to add something to this? Or Nita, would you like to ask us something about this? Or I would probably say, Nita, how do you do it in your clinic? So once they start talking, that initial hesitation goes. And the distance is no longer important. Once you know someone and you're calling them on a first name basis, the distance is no longer important. And the people who prefer to stay quiet, we don't trouble them too much to talk also, because some people walk out if you start calling them too many times. There are a lot of naturally shy people also in the audience. But another good way is to ask the people who are not talking much to present cases. So give them a timeline. Okay, then you come up with a case in the next 3 months, so that they don't hurry and they become more participatory.
Yeah. Thank you, Upasna. Dr. Azizullah wants to ask a question.
Thank you very much for the nice presentation. Sorry that I couldn't write the chat because I'm using my mobile and I have no access to my laptop. In this case, I would like to ask you the question directly through mobile. I have two questions. One would be from Bruce and Armistad and Miss Armistad, and the other question would be from Miss Agarwal. I will ask the first question from Miss Agarwal. The ECHO is a new approach which we wanted to apply in August 2021 in Afghanistan with the National TB program. Unfortunately, while the Afghanistan government collapsed, all the system was collapsed and we couldn't apply the ECHO in public health facilities, especially with Ltbi. Now, I would like to know about the AFB training, because Agarwal explained very well that they engage most of the clinicians and health facilities and they expand the program. It's possible that we could launch the ECHO to conduct the AFB training as well or not. The other question is about Bruce and Agarwal, and Bruce and Armstead, maybe they can respond to this question. Unfortunately, while the previous government is collapsed and the Taliban captured Afghanistan, the US said restricted us that we should not contact with the new government, especially with the NTP, Ministry of Public Health and public health facilities. In this case, now we are restricted and we are not able to contact them directly or indirectly. In this case, we would like to launch the ECHO program in private health facilities. Any challenge would be faced while we are launching the program with private health facilities, because they are not committed people and they are working for profit. In this case, for launching the ECHO, we will not provide any incentive for maybe profit for them. Bruce or Army or Armstead could solve this problem. If there is any guidance from them, we will consider while we are launching the program with private health facilities. Thank you very much.
So, hey, Aziz, great to see you and thanks for joining and thanks for those excellent questions. I actually think Dr. Agarwal, who has worked with private sector TB practitioners, would be the optimal person to answer your question. But Amy and I will circle back to you by email to follow up. But Upasana, might you have any recommendations to Aziz about working with the private sector and engaging them?
Thank you, Aziz, for asking these questions. Taking the first question that you asked me, not every clinic needs to have like permission from the national program. Among all the clinics that we have, as you said, that the national program has collapsed for some time with the collapse of the government, our HIV and our HIV program definitely has permission from the central government, but our medical colleges program, our peripheral worker program, not everybody has to come through the national program because it is basically a learning platform. It's a peer learning platform. And if you have established yourself, if you are an established leader in the field of tuberculosis in your country, your region, your state, or probably your district, you could make a small beginning by inviting your, like how we started was we invited our tentative spokes, our colleagues, for a small meeting and it was about peers talking to peers that, okay, we have to set up this community. The same can be done with you. You will have to approach your private practitioners in some manner, either a one-to-one meeting or a telephonic call or somebody. You will have to get people excited about it. Now, once people get excited about it, it could be private practitioners, it could be university hospitals, it could be peripheral health workers. It's basically about getting your colleagues excited about developing a learning community. That is actually all that I would be able to say about that. We did different things for different clinics. So there is no, it's just how you get them on board, how you get them excited, how much do they accept you as being the hub. That is usually, sometimes that gets to be like a tussle. There are people saying that, why do you want to be the hub? We are also good enough to be a hub. So you just have to keep a participatory approach, and I think it would work.
Yeah. Thank you, Upasana. Thanks a lot. Thank you, Dr. Bruce. Now, I would like to close this session. And before closing this session, I would just like to say that India is one of the success stories for tuberculosis ECHO, where we have expanded a lot. We have almost 65 hubs running for the tuberculosis, and we are partnering with Union for iDefeat project, where we are involved with many NGOs and we are running many centers through them. We are working in the field of TB, cancer, maternal health, hepatitis. So there are many things that we are covering, but it's been a slow and learning journey, and a lot of commitment is required for sustainability. Thank you. With this, I close this session And I now move over to the next speaker of the day. She's Lilith Chatran. She's MD MPH for TB, and she works for TB and HIV grant program. She's coordinator of the Global Fund Program Coordination at the Team of Ministry of Armenia. Hello, Lilith, and we can read more about Lilith in the chat section. So over to you for your presentation.
Thank you, Nita, for the introduction. I'm going to share the screen now. Can you see it?
Yes.
Okay. I'm going to present the National ECHO program in the Republic of Armenia. And first of all, I have to state that I have no conflict of interest to report. My presentation is called the National ECHO Program to Strengthen the Drtb, TB HIV, and TB HCV Care and Treatment in the Republic of Armenia. Project ECHO globally was originally designed and developed by the University of New Mexico, and it's a global movement engaging over 500 partners worldwide in more than 35 countries, with a mission to democratize knowledge and amplify local capacity to deliver best practice healthcare to underserved people all over the world. A few words about Armenia. Armenia is a very small country located in South Caucasus. It's Eurasian, with population of about 3 million, and GDP is about 13 per capita. Capital city is Yerevan, and we have TB outpatient decentralized service in the country with 58 TB cabinets, which are located at primary healthcare facilities throughout Armenia. A little bit statistics on MDR, XDR, TB epidemiology. These are the data for 2020. Armenia is a high priority country in the WHO European region for MDR TB, and MDR, XDR TB rates were 13% among new TB cases in 2020, and a bit more than 44% among previously treated TB cases. The treatment success rate is quite low. It is 46% for the cohort of 2018, far below the targets of WHO and the Global Fund. And the loss to follow-up is quite high, 26% in the cohort of 2018. If we see the treatment outcomes for MDR TB, we can see that about 26% of loss to follow-up is contributed by labor migration. It is 55%. Those are people who permanently live in Armenia, but go for seasonal work to neighboring countries, mostly to Russia and Ukraine, and come to Armenia, and we call them labor migrants. 32% those who just refuse the treatment of TB. And among the reasons of death, which is about 15% of treatment outcomes, we can state that about half of the deaths are contributed to TB, and about 40% to TB HIV co-infection. Why TB ECHO project? We understood that there is a lack of TB specialists at the peripheral level in the country, not in the capital city. We had difficulties in treatment monitoring, and we need quality improvement. There is the DR committee, which is the only eligible entity countrywide that makes decisions for DRTB treatment and treatment monitoring in the country within the National Center of Pulmonology, and runs the National TB Control Program in the country. And also we evidenced the successful experience of TB ECHO and HCV ECHO projects in our neighboring country, in Georgia, where we had a study visit. Project ECHO in Armenia is a joint model of medical education and teaching using case-based learning. And real cases are presented by participants. It enables a service provider to provide better care to patients where they live. And it uses Zoom technology, which is a free web-based video conferencing system that allows to join sessions from anywhere. Opportunities of ECHO project are really very good because it is very good for resource limited settings, and Armenia is such a country. In Armenia, as I mentioned, we have this TB decentralized medical services. We don't have it for HIV service yet, but we are also planning to decentralize at least the diagnostic services for HIV for the upcoming years. ECHO provides a good opportunity to save on travel and accommodation costs, which is very good for resource limited setting. And it's a flexible project, and it's very good, particularly in emergency situations and outbreaks like the outbreak of COVID-19. Here I present the current structure of TB ECHO project in Armenia. We have 2 ECHO hubs in the country. One is located at the National Center of Pulmonology, the other at the National Institute of Health. We have 58 TB cabinets in Yerevan and peripheries as ECHO spokes. And we organize monthly clinics as ECHO sessions, and we have the potential to arrange bi-weekly or weekly meetings in the future. We have the ECHO didactics, and we have multidisciplinary attendees to these sessions. What are the planned activities and expectations from this ECHO project? It is the international involvement, particularly in the field of pediatric TB, complex TB cases and management of adverse events, TB and comorbidities, and guidelines on latent TB infection. We plan also to extend the HCV ECHO project, TB HIV ECHO project, and we are going to develop credits for continuous medical education training to encourage participants. A few words about the initiation and progress that we have to date. So within the framework of the Global Fund grant, strengthening control of TB and HIV/AIDS in the Republic of Armenia, which was effective from 2018 to 2021, the professional service agreement was signed between the University of New Mexico and the Ministry of Health on May 21 in 2020. Then in June 2020, the Armenia team, including representatives from the Global Fund, PCT based at the Ministry of Health, National TB Program, and the National Institute of Health took part in virtual standardized immersion training. An action plan was developed to schedule activities, stakeholders' duties, and deliverables. Then we arranged periodic online calls involving all stakeholders, typically once a month. And Armenia team was provided with access to the Project ECHO resource library on Box, Zoom video conferencing software, iECHO outcome tracking software in October 2020. We had our first spoke training on February 24, 2021, with selected 10 TB cabinets as a pilot. We carried out needs assessment of technical needs and training needs in March, April this year. And based on this needs assessment, equipment, computers, laptops, web cameras, earphones, and the Logitech system of video conferencing were procured and donated to the country by the Asian Development Bank. So in fact, ECHO Armenia project launched in July 2021. And to date, 61 medical centers have access to ECHO project. 79 contact persons have been trained. Currently, we have 61 ECHO users and 3 ECHO clinics for TB, HCV, and DR committee. We use this opportunity also to conduct trainings for the upgraded ETB manager system, electronic database system, using this ECHO platform in October this year. And we managed to arrange 12 courses, and we had 30 participants throughout Armenia. Those are some slides from the SPOC training. A couple of forms that were developed within this ECHO project in Armenia. This is the patient treatment evaluation form, HCV monitoring form. And I want to indicate some obstacles and risks that hampered the implementation of ECHO project in Armenia. Of course, first of all, I would like to mention COVID-19 pandemic, which with restricted transportation and lockdown in the country, and this delayed the implementation. Delayed the implementation of the ECHO project in the country. The lack of face-to-face meetings and trainings before the launch. We were supposed to visit the University of New Mexico and have the immersion training there, but because of the COVID pandemic, we did it online. The new format is really new for us, for the country, for everyone, not only the participants, but also the people from the National TB Control Program. The procured equipment was delivered with a delay in the country, again, due to the COVID pandemic and the restricted transportation. We have another obstacle in the country, that most TB doctors in the country are of advanced age, and they are typically resistant to using new technologies, Zoom-based clinics. And of course, the risks for sustainability, because now currently our country is facing competing activities, and the budget expenditures in the healthcare sector are reprioritized due to the consequences of the large-scale war between Armenia and Azerbaijan over Nagorno-Karabakh. With this, I would like to thank our colleagues and mentors from the University of New Mexico ECHO team, the Global Fund for funding this project, the Asian Development Bank, and also the Union for this wonderful opportunity. And with this wonderful view from Yerevan and Holy Ararat in the background, I'm finishing my presentation and ready to answer to your questions. Yes, we have a couple of, in fact, 3 poll questions. So I would like to ask Diana or Nita to start with a poll.
And the polling is up, so everyone, if you would like to go ahead and answer some of the polling questions, and Lilith will kind of go over them as we receive the answers. Thank you very much for your presentation, Lilith.
Welcome. Does it work? Ah, okay.
There we go. Yeah. It took everybody a minute to find it again, didn't it?
So we can reach the 50% of
it
participation and then stop the polling.
It looked like maybe the poll was ended early. I don't know. Can it get relaunched perhaps?
I'm going to try to relaunch it. Yeah, I think someone touched it.
Oh, I see. Okay.
And Lilith, it's Bruce. You may want to read the questions for people, read through them.
Okay, sure. So the first question is ECHO virtual communities. Communities of practice. Oh, sorry. These are repetitive questions. Something is wrong here.
Yeah, Carolyn, I think this was the first set of poll questions, not the ones for Lilith.
This one is the right.
There we go.
Right.
Great.
Yeah.
Can you
This
read
one.
them, Lilith, for everyone?
Yeah. Project ECHO is developed to make knowledge more accessible, utilize international experience in the local context, deliver best practice in healthcare, combine medical education and case-based learning, all of the above, A and D.
And then Lilith, you may want to read the second and third questions, which are up there for everyone also.
Project ECHO is useful to evaluate participant satisfaction, knowledge assessment, key performance indicators, patient's health and treatment monitoring, B, C, D, all of the above. And the last question, Project ECHO may be used to connect healthcare professionals within the country, connect healthcare professionals with the subject matter experts, provide continuous medical education credits, healthcare professionals based on knowledge assessment via pre and post training, simplify the delivery of knowledge and share experience, all of the above. Oh, we have 25% of participation so far.
It looks like everybody maybe is a little sluggish on the polls, so we might not reach the 50% on this one, huh? And as everybody is still answering the polling, are there any questions for Lilith that you would like to put into the chat box that she could address? It doesn't look like I'm seeing any questions in the chat. Should we just go ahead and end the poll now and you can provide any closing comments about the poll, Lilith? Would that be okay?
Yeah, sure. So all three correct answers are all of the above. So for the first question, most of the people participated, answered correctly, all of the above. Again, the second question, all of the above is the correct answer. Oh, we have about 50% who answered B, C, D, missing the one, participant satisfaction. And the third one, again, all of the above is the correct answer, and most of people participated, answered correctly. So, are there any questions in the chat?
No, I don't think I see any right now. So thank you very much for your presentation and for the polling questions. And if anybody does think of a question for Lilith, you can always post it in the chat later and she can respond directly into the chat also if you have a question that comes up later. So we will go ahead and transition to our next presenter now. And I would like to introduce Dr. Jonathan Heirloo, and he's the Indian Health Service Chief Clinical Consultant for Infectious Disease, and he has a special interest in HIV, TB, and sexually transmitted disease in rural areas. And so, Dr. Heirloo, I'm going to let you go ahead and take it over now. You're still muted, Dr. Heirloo.
Thank you so much for inviting me today. I'm John Heirloo. I'm an infectious disease doctor who's worked for the Navajo or Indian Health Service for the last 27 years. I have no conflict of interest to report, and the things that I say today do not necessarily reflect the view of the Indian Health Service or the US federal government. I'm going to start with a case presentation. An 86-year-old woman showed up at our hospital in the spring of 2021 at the height of the COVID pandemic. She has diabetes and previously received isoniazid for a positive TB skin test, On physical exam, she was afebrile, had a normal exam. Her laboratory data were normal. PCRs for SARS-CoV-2 were negative ×2, but a chest X-ray showed a rounded infiltrate in the left upper lobe. We admitted to the hospital. We checked 3 sputa for AFB and also PCR, and finally TB-RIF expert assays, all completely negative. The patient's family did not want any further workup. She was discharged. 3 weeks later, she had TB. Why did this happen? Well, to give a long answer, there was first contact between American Indians in our region and Europeans in 1609, as evidenced by this rock formation near my home. You see an American Indian petroglyph in the background, and then superimposed on top an inscription in Spanish from 1609. In 1846, the United States Army invaded this area. And in 1864, this gentleman, Kit Carson, forced the Navajo people to go on what was called the Long Walk, where they were forcibly relocated to what's now eastern New Mexico, at a place called Fort Sumner, where people immediately started to die of yellow fever and cholera. After a few years, they were released to return home to their homeland called Dineta. But rapidly, consumption was diagnosed by some of those first clinicians. And so by 1912, 10% of the Diné or Navajo people had TB, and TB was responsible for about half of the illnesses. And later, about a quarter of the deaths on the Navajo Nation were caused by TB. And early sanatorium in the first year, about 2/3 of the patients had died of tuberculosis. So a tremendous impact on Navajo people with this disease. Even in the 1950s, TB incidence among the Navajo was 100 times higher than US all races, and TB mortality was 10 times higher. So what was done to address this was the creation of the Navajo Nation TB Health Worker Program. And in this picture, you see my late colleague, Mrs. Sarah Yazzie, a member of the Navajo Nation, who ran the program from the 1970s, involving home community health representatives who went into patients' homes and did directly observed treatment for tuberculosis. The typical day of one of our workers is to drive up to 200 miles on roads that look like this in good weather. And sometimes during the monsoon season in the late summer, it looks like this. So very challenging work that these folks face. But they have a great success in doing this. We do 100% DOT for TB disease. And now using 3HP, we do 100% DOT for TB infection. Our strength is using bilingual care and bilingual workers to do care and contact investigations. And we integrate Navajo traditional medicine into the care of our patients. The hallmark of our team work is compassion and patience with the patients. So our Mrs. Yazzie would go into the homes and treat the patients as if they were family members. And she taught generations of TB workers in our area to do that kind of approach to medicine. And we also were able to train primary care providers across the Navajo Area Indian Health Service to become the local TB experts. And I'll show you how we did that. The answer is Project Echo. In 2013, at the urging of Dr. Bruce Strumminger, who you can see here on the screen, we started an Indian Health Service HIV Echo, and very rapidly were able to train beginner physicians and other workers, pharmacists, to become HIV experts after attending sessions for a couple of years. So we set up monthly teleconferences with University of New Mexico, didactic talk, you know the drill. We discussed 2 or 3 cases. And since that time, we've taught 261 individual attendees, usually average about 12 persons per clinic, and have treated 134 patients this way. The tuberculosis echo started as a collaboration between the Navajo Area Indian Health Service, and the New Mexico Department of Health and Arizona Department of Health. We started this in the year 2000 as a monthly telephone call. We would discuss patients the old-fashioned way, but this evolved into an echo teleconference in January 2016. And Diana Fortune was very catalytic in getting this started. She urged us to do it, and we finally got it rolling in January 2016. We meet monthly to discuss every single patient in our region who has TB disease. And we also discuss patients who have complicated latent tuberculosis with comorbidities, drug interactions, and allergies that make treatment problematic. We usually have a nice didactic talk by a specialist that's addressed for the generalist provider and also for the tuberculosis technician. So we have things that are relevant on all levels, from the provider, pharmacist, to the technician who's going into the homes doing the actual care. So what are our statistics? We've had a total of 65 sessions, 108 unique attendees, and 13.4 persons attend per session. And we've managed the care of 133 unique patients during these echoes over the last few years. So echo is a huge in Indian country, and I'm talking about American Indian country. Every dot you see here shows where there are echo programs. We have programs in the Indian Health Service for treating tuberculosis, HIV, hepatitis C, rheumatologic diseases, substance use disorder, emergency medicine, and COVID-19. So we are very, very involved in using echoes across the United States in Indian country. So that's a beautiful picture, echoes everywhere. They're working really well. But then came this problem in March of 2020. My part of the country, on Navajo area, became the hardest hit by the virus. This is an article from the New York Times, and one of my colleagues, Dr. Mahani in the center, with his team doing outreach at a local motel to take care of people who have no home. So what did we do during the pandemic? In March 2020, the virus first came to our area, and within weeks, our hospitals in this region were inundated with patients who had COVID-19. And most of our public health resources were diverted to COVID care. Our TB technicians working for the Navajo Nation were able to continue their activities. They could do DOT with what I would call outdoor porch visits. They would go to homes at remote sites, hand out medicines, wearing full personal protective equipment, and continue their activities. We had a temporary shutdown in our TB Echo teleconference, roughly 3 months, but we're able to resume it early in the summer of 2020, and we've maintained it throughout the pandemic, even during the worst months. And so what has been the effect? We have seen a nice, using the echoes, which we've done for the last 4 years, and going way back using this home visitor program, we've had a diminution in the number of cases of tuberculosis on the Navajo Nations. In green, you see back in 1990, we had 25 cases per 100,000 per year. Now we're almost down to the rate for USL races. So we have a fairly successful program. And I think ECHO has played a big role over the last 5 years in making this possible. So in conclusion, TB care was significantly impacted by the COVID pandemic on the Navajo Nation, but our team was able to continue to do home care in this really high-risk state by being very careful and doing home visits with personal protective equipment. The Indian Health Service ECHO program has made remote case management of challenging cases and provider education possible. And we were able to take generalists and people who had no knowledge of tuberculosis and gradually are making them into TB experts. And fortunately, I'm happy to conclude that TB incidence continues to decline on Navajo. So that concludes my presentation. Are there any questions?
Thank you, Dr. Heirloo. There are no questions on the chat. Is there a poll?
Nita, I have a quick question for John, which
Yes.
is that many of the other programs we're going to hear about describe TB echo in high burden TB settings. And your program, one of the needs was really supporting knowledge of practitioners who don't work on TB full time because they're in low TB burden settings. And most of the doctors and nurses have do other work, and TB is just one part of their work. So I'm just wondering if you could speak to that. In India, it's the full-time TB clinicians who participate in ECHO, whereas on the Navajo Nation, the doctors and nurses often do multiple things.
Exactly. So we do see some overlap between the HIV, hepatitis C, and tuberculosis clinicians and staff. But in general, these are folks who are busy 90% of the time taking care of persons with diabetes and cancer and other problems. So our goal in the Navajo Area Indian Health Service is to take generalists and people who are not TB experts and try to raise them to the level where they can manage tuberculosis independently or with very little guidance. So it is a different situation from some of the other programs.
Thank you, Dr. Heirloo. There's one question from the registrations that we've got. How are the needs for technological equipment addressed? Did you have any issue?
Yes, so we live in a part of the country that has low bandwidth, so it is not uncommon for us to have to turn off our videos. There are sometimes people have to connect only by telephone. We have sites, very large parts of our area, there is no cell phone coverage, so it is actually very challenging. So bandwidth is a big deal, internet connectivity is a big deal, but usually the workers and the physicians and the pharmacists are located at hospitals that have some internet connectivity.
Thank you. I think that's very helpful to know because most of the countries, and especially the remote parts, have these issues. And it's good to hear from you how you have tried to overcome this issue.
Yeah, the solution is one of these when you can't have internet connection directly.
Yeah. Thank you, Dr. Heirloo. Thanks a lot. And now we shift to next session. That's by Daria, and she's a DO MPH. She's assistant professor in family medicine at the Warren Alpert Medical College of Brown University and adjunct assistant professor in family medicine and community health at University of Massachusetts. Over to you, Daria.
Great, thank you so much for having me today. Good morning, good afternoon, good evening to all the participants. And thanks for all of the really great talks that we've had so far. So I'm also going to be talking about a similar topic that we just heard about advancing TB prevention and implementing the ECHO model to increase LTBI testing and treatment in primary care.
Daria, you might want to put it in presentation mode. We're seeing both. You might have to go up to that switch screen, the swap monitors at the top, I think, because we're seeing your next slide. There you go.
Is that okay?
Yep, you got it now.
Okay, excellent. So sorry about that. I thought I had done that right. All righty. I have nothing to disclose. And what I'm hoping that all of you will get from this by the end is that you'll be able to describe how the ECHO model can be used for latent TB infection education, and that you'll be able to explain the Morris framework and how it can be used to evaluate various aspects of an LTBI ECHO program. And finally, describe how mixed methods evaluation can be valuable to an ECHO program like the latent TB infection ECHO. So as you just heard, in the United States, latent TB infection is our biggest problem. It's believed that 4.7% of the US population are infected, which is about 13 million people. And unfortunately, this disproportionately impacts non-US born individuals, with about 20% of non-US born being infected. And about 71% of our active TB disease cases in the United States represent reactivation from latent TB infection, which really demonstrates a missed opportunity in care and really highlights the inequity in tuberculosis in the United States. In 2016, our United States Preventive Services Task Force, which is an organization that creates preventive screening guidelines, encouraged primary care providers to screen and treat latent TB infection in primary care, which was not really something that was routinely being done. Previously, it was often left to specialists. So understanding the latent TB infection care cascade and all of our TB cascades in general is incredibly important to be able to see where we can better bring people into care and get them through treatment. And I think that this is likely very familiar to many of you who are part of this course. One thing to just remind ourselves of is that there really can be losses of patients at each of these steps. And given that we have such an international audience today, I wanted to be able to actually look at the LTBI care cascade as it looks in practice in the United States. And so a patient comes to a health center, perhaps their primary care provider might see them and order a TB infection test as part of routine primary care. If the test is positive, the patient is called and a chest x-ray is ordered. The patient then might have to return to have the x-ray done. And if it's negative, the patient then is asked to return to the health center to discuss what this means. And then they go on to be referred to a TB clinic, because most of TB care is done by specialists, which often involves taking a bus, perhaps to a faraway town or city. And then it includes multiple visits to the pharmacy and that TB clinic. So when we think about where losses might occur, you can imagine that many of them are actually happening at this referral step. And this is really due to many patient and system level barriers that decrease the chances of successful referral completion. And in my mind, if we could eliminate this step and really keep latent TB infection treatment within the health center, many of these barriers would actually be eliminated. And so that brings us to this question of how can we create primary care latent TB infection champions? And this is really where the ECHO model comes in. So as you heard from Bruce earlier, ECHO has been used globally for democratizing TB knowledge all over the world for many years. And in the United States, programs really, as we just heard, have historically focused on active TB disease management or a combination of both TB disease and TB infection, which isn't always geared towards primary care providers. So our team worked to implement latent TB infection only echoes that are really geared towards primary care providers and primary care team members, so nurses and other medical providers. And I'm going to take you through how that's evolved so far. So in 2019, the University of Massachusetts and the Department of Public Health in Massachusetts partnered to create the first latent TB infection echo in the country. And this introductory LTBI echo course was successful, so we ended up repeating it in 2020. We then recognized the need from previous participants for a more advanced program, so we created a longitudinal monthly course for beginners and experienced participants to engage in and review more complex cases. The results from that echo really were promising, and so led to a collaboration between the Rhode Island Department of Public Health and Brown Medical School, which then led to a creation and replication of a 2021 introductory latent TB infection echo. The introductory courses have all followed the same format. So we have 10 minutes of introductions and housekeeping, 15 to 20 minutes of didactic sessions by a content expert, and then the remaining time is case presentation and discussion for the introductory course. And there are 6 sessions as part of that introductory course that really focus on all aspects of the LTBI care cascade. And we have one launch session in the beginning to get everybody on board with the ECHO model. We offer continuing medical education credit to participants, so 1 credit per session, which is also an important component of ECHO. An earlier question related to evaluation, so I wanted to spend a little bit of time on our evaluation strategy, which for us included mixed methods and also uses the Moore's framework to organize our evaluation efforts. So the Moore's framework is a framework that's used to help establish as well as assess continuing medical education activities. And it really ensures that what you're setting out to put together in your educational activity actually meets your anticipated goals. So there are different levels of learning to consider as part of this framework. And when you're thinking about setting up an ECHO program, you might want to consider how you're going to evaluate at the highest level possible in this framework. So using the latent TB infection echo as a model, level 1, which is course participation, can be evaluated from attendance records as an example. For level 2, satisfaction, this can come from post-session evaluations and from our qualitative interviews that we did. For level 3 and 4, which gets into knowledge and competence, you can use pre and post-course surveys. For performance, you can have participants report performance on pre and post-course surveys, and then also in qualitative interviews. Level 6 and level 7, which focus on patient health and community health, are definitely harder to achieve. And only several echoes have really been able to integrate these levels. So I think that this framework can really help with planning your echo activity and put together an evaluation strategy that will actually help assess your impact. I wanted to share the results from our most recent introductory course in Rhode Island. So we asked individuals to rate their confidence in performing each of the areas of latent TB infection practice that you can see here. And as you see, the majority of the areas, there's a statistically significant difference in confidence for all but one question and across all areas. We also added a question on the post survey asking individuals to talk about whether or not they changed their practice as a result of the course. Since practice changes often getting into the performance level on the Morse framework, and it can be useful to try to get a sense of. 75% of participants said that they indeed changed their practice, which was absolutely fantastic. I really can't speak enough for incorporating qualitative interviews with participants into your echo models, and these interviews do not need to be extensive. We ended up doing 4 interviews with folks from Rhode Island, and as you can see, one of them said, "I can now better explain LTBI to my patients. I have a better understanding of it now. I changed to rifampin from INH and B6, which is much better for my patient population." This is really an example of data that you just can't get from a quantitative survey. And so if you really want to get into that practice change and you're not able to evaluate patient level outcomes, qualitative interviews are certainly beneficial in that regard. So I want to end by just mentioning where we are now with the LTBI echo. It didn't really make sense for states in smaller areas to replicate the introductory course. So out of this work has come another initiative, which is a regional introductory latent TB infection echo course. This initiative was just launched in September of this year, and it's a collaboration between the Global TB Institute, which provides education to a program area of 16 states and 4 cities in the northeastern part of the United States. And that's in collaboration with Brown University and, of course, Project ECHO. Since we're taking on such a large program area, we really had to be strategic about our recruitment. So we decided that we really wanted to target health centers that serve at-risk populations, so those patients who are non-US born. And so we worked with departments of public health throughout the region to identify 3 health centers in each state or city. And then we asked those health centers to further help us recruit about 2 to 3 providers from the center. So the target ended up being about 100 primary care provider participants. We have our last session happening next week, and you're actually the first group to see our demographic data from this course. We've had 42 participants attend at least one regional LTBI echo session. 93% of them have identified as female, 88% are physicians, otherwise they are mid-level providers like physician assistants or nurse practitioners. And participants have attended on average 3 sessions. You can see here the breakdown of how many participants from each state or city are involved. So for me, the regional LTBI echo really highlights the importance of strong partnerships and collaborations that can develop from echo models. For this program, the Global TB Institute already had great relationships with departments of health in the region, so our team was able to schedule meetings and hear each program area's needs and hopes for the upcoming initiative. Our team already had echo experience, so we were able to focus on some of the logistical aspects while Global TB Institute really fostered those ongoing relationships to recruit participants. My co-facilitator is a nurse practitioner, so since both of us are primary care providers, we had access to a network of PCPs in the region. And I think we were able to help convince PCPs that compared to everything else they do in their practice, taking on latent TB infection isn't actually that big of a deal. So ultimately, I might be biased, but I truly believe that the LTBI ECHO model is a critical strategy to eliminate provider level barriers and is key towards TB elimination in the United States. If you recall our patient from earlier, you know, we watched them go through the LTBI care cascade. If we can democratize LTBI testing and treatment knowledge to primary care providers through the ECHO program, patients can get treated in primary care. And that really is the ideal system to move us towards health equity in the United States. So I will stop there and take any questions. Thank you so much.
Yes, thank you very much, Daria. That is so super to hear about, using Project ECHO to treat TB infection. So that's really cool to hear how that's expanded so well. Does anyone have some questions for Daria? If you do, put them in the chat.
Dr. Swarko, good morning. Thank you so much for your nice presentation. I just had a quick question in terms of the impact of your project. How have you reached out the homeless population? Do you have any data about that? Particularly in the cities that you have implemented it?
Well, that's a fantastic question, and we don't have any data related to that. Given that we aren't able to collect patient level outcomes, we haven't been tracking specific patient demographics, but certainly that's a fantastic question for us to ask our participants. So I appreciate that, that suggestion.
Because I often see that, you know, when we talk about urban poverty in these major cities, Boston, Columbus, and I've experienced that it's a lot about what we are really not reaching the hard to reach. You know, it's just not the underrepresented communities of color, but it's really the homeless population that are really at highest risk as well. So thank you.
Thanks so much for that question.
And Daria, we do have a question in the chat from Donna Wegener, and she says, thanks for your great presentation. As you finish the first course, are there plans to continue this with a second cohort of providers in the same region or perhaps expanded?
Yeah, thanks so much for that great question, Donna. So we do have plans to repeat the introductory course in 2022 with the Global TB Institute in the same region. I think there are still many providers that we have not reached yet. And so we're going to be reaching out to other health centers and even some of the same health centers to continue training primary care providers.
Okay, and we still have a couple of minutes left if there are any questions. I know, Daria, you had elected not to do your polls because you didn't want to eat up the question time. Do you want to go ahead and pop those in since you have a couple of minutes left?
Why not?
Stimulate some questions in. So, okay.
So I can read these out. So the first question, the blank framework is a conceptual model and an expanded outcomes framework that can facilitate planning and assessment of continuing medical education activities, such as ECHO programs, to achieve desired outcomes. And the next question is, the following research methods can be used to evaluate an ECHO program: quantitative only, qualitative only, mixed methods incorporating both. And then the duration of an ECHO course is short, typically fewer than 10 sessions. Long, typically lasts for several years to ensure community building. Any duration, typically the number of sessions, is determined by the course objectives. And I'll give it a little bit of time for participation. Ooh, we're getting up to 25%.
Hey.
Let's see if we can get a couple more. Thank you, everybody, for participating.
And as you're doing the polling, if you have a question, go ahead and pop that into the chat box and we can get to that also.
Great. I see the numbers slowing down, so perhaps I'll end it and then read out the answers. Okay. So the framework is called the Moore's framework, and I did include the reference on the slide to that great article if you want to read more about it. And then the second question related to research methods, certainly mixed methods, and I highly encourage all of you to try out qualitative because I think it's really helped us to learn a lot about our program. And then Number 3 was a little bit of a trick question, I guess. So the duration can be really any duration. And that really is dictated by your course objectives. So we're doing both the short course for the introductory, but then Massachusetts is continuing on with the advanced course that's monthly. And so it's really whatever works for your participants. Thanks.
Thank you very much, Daria, for that presentation. And now we've come to the time on the agenda where we're going to take just a short break. But don't forget to come back because we do have a presentation from one of our colleagues from Tanzania, and then we'll follow up with the worksheet that we're going to go over and helping you develop new programs. So I think they're going to put up a counter for us, and you got 10 minutes to go have a short break, and we'll see you back shortly. Welcome back, everyone. Mr. Timer Snowflake says our 10 minutes is up. That was a very nice little timer that we had to count us down. So I hope everybody had time for a brief refreshment. And we do have one more presentation, and it will be by Peter Dowd. He's a registered medical doctor and a clinical research doctor with experience in treating multi-drug resistant TB and extensive drug resistant TB at the Infectious Disease Hospital in Kilimanjaro. So I would like to welcome Dr. Dowd to share his experiences with ECHO.
Hello, good evening, good morning, everybody.
Hello, and do you want to go ahead and pop it into presentation mode?
Yeah, yes.
Okay.
Is my slide visible? Sorry.
It's visible, but if you want to go down, to the lower part of the screen and put it into the presentation mode, it'll make it a little bit larger for, yes, right there. Perfect.
Okay. Thank you for having you, all of you from different groups around the globe. And as I have been introduced that I'm a medical doctor here in Tanzania at the National Center of Excellence, Kibongoto Infectious Disease Hospital. But today and here I work as a medical doctor, but also I'm the National Drtb Echo Coordinator. So today I will share some of the few experience and what we have gained through Project Echo. So, and my presentation will be on to share the contribution of Project Echo in reducing the cost of tuberculosis treatment service here in Tanzania. But I have nothing to disclose. I have no any conflict regarding to this presentation. The little bit introduction, I will cover the why MDR TB Echo in Tanzania. What was the reason which led us national TB program to see the potential of introducing the MDR TB Echo in Tanzania? As per WHO current data, Tanzania is one of among the 30 countries with high TB burden in the world. And in Tanzania, officially, we started treating these MDR TB patients in 2009 at a single center. But before, we had no any center of treating these patients. They were treated all over scattered with any formality of treating them. But in 2009, the WHO devised through our Ministry of Health, devised them to start treating these patients at a single hospital center. And when they looked, we had an ancient hospital called Kibongoto Infectious Disease Hospital. This hospital was built almost 95 years ago. So it was this hospital located around the base of Mountain Kilimanjaro, and it's the ideal center to manage these patients. So in 2009, we started this program of treating these MDR-TB patients with only 12 patients. But this patient was increasing steadily as the new technology was coming with the mode of diagnosing these patients. But the KIDH or the Kibongoto Center has only a 330 hospital bed. And the only mode of treating these patients was the mode of hospital model to stay. So the patient has to travel all over the country, travel miles to come here to Kibongoto and to stay at a minimum of 1 year. So now you can see where one patient occupying a bed for 1 year, and the hospital has only 330 beds. So this led to overcrowding of patients in the ward, and led to patients attempting suicide due to depression, because in our culture we are not used to enclose patients like prisoners. So by the end of 2016, our Minister of Health, through our national TB and leprosy control program, now decided to decentralize this MDR-TB service from the hospital mode of care to decentralized or to home-based mode of care. But this had a lot of challenges, since most of the healthcare workers were not trained to manage these patients. But the issue of managing a side effect, and another issue was to keep up with the current updates. As you can see that from 1996 to around 2008, there have been a lot of changes, the guideline, the WHO recommendations and the guidelines. So to keep up with this, to keep up the update of our healthcare workers and to keep up the pace of this new rapid recommendation and guidelines, this led us now to think of what can make us to keep up with the pace of these recommendations. So, what was the reason? That to keep our healthcare workers updated, but also the training costs of the face-to-face training here in Tanzania is very costly. Now you can see maybe around 500 USD to train a single healthcare person for 5 days. So to keep up with the pace was not really feasible. So one of the reasons which led us to initiate MDR-TB echo services in Tanzania was to reduce the cost of providing the face-to-face mentorship to our healthcare workers. But also, as I said before, that the mode of treating this patient from 2009 to 2016 was the hospital mode of care. So all the patients diagnosed with MDR-TB patients here in Tanzania was required to be transferred to a single center. So this we encountered a lot of cost, fuel costs, paying healthcare workers to go and pick up those patients. So, but another reason was why we thought that now we need the MDR-TB echo was to reduce the time of treating these patients. We know that diagnosis was delaying when the patient, suppose, is around 500 kilometers and need to be transferred here at Kibongoto. The hospital has only 2 ambulances. So only 2 ambulances cannot rotate all over the country just to pick ups. So most of the patients, by the time they went to pick them, they found they were already dead, or they had a lot of disseminated the disease. So all these challenges led us now to think that it's time now to adapt this a feasible mode of disseminating information. But where we came from here in Tanzania, it was early 2017, where through our former collaborators, the KNCV, in collaboration with our national TB program, now formulated an idea of how can we keep up the pace of WHO recommendation, but what is the sustainable mode of providing the health education, MDR-TB health education to our healthcare workers. Now, in 2017, I feel our colleague was sent to New Mexico for just to be oriented on this eco model. And now we piloted, we started to pilot by using, by that time it was only 6 sites, it was in Dar es Salaam and at the hub here at Kibongoto. And in 2017, around August, we had a successfully 2 eco sessions, and for us was an achievement. But as you can see from the graph, the situation of the MDR-TB in Tanzania, as you can see that we started officially with the 12 patients in Tanzania, but the diagnostic tools was increasing, but because by 2009 we had only a single gene expert and it was located at the central reference lab. But from 2010 and around 2010, we had almost more than 50 gene expert machines. So the diagnostic tools, which was now available around 2018, it's like a real-time PCR. In 2 hours you have your result. So this led to increased number of increased number of patients. But as the number of these patients was increasing, healthcare workers needed to be trained. WHO was releasing multiple recommendations around every 1 to 2 years. So through this data made us to get the support that we are now, it's time to start MDR-TB echo, the sustainable mode of providing a continuous health education to MDR-TB service here in Tanzania. But sharing experience, we have been using this MDR-TB echo platform for providing health education to those healthcare workers that are in the periphery, but we have also been using this eco platform as a capacity building, but also we have been using this MDR-TB eco platform to initiate to provide a timely management to a newly diagnosed MDR-TB service. As since we decentralized our service from hospital of care to home-based of care, home means of care. So now from 2017, there were no need now to transfer patients from peripheral hospitals to bring them to here at Kibongoto. So when the new patient is diagnosed, there were no need to send a team at the nearby hospital facility to provide the on-site mentorship. But now we from 2018, we decided now to use this eco platform to provide a virtual on-site mentorship for treatment initiation, but also to provide a follow-up for this newly diagnosed MDR-TB patient on treatment. So using this platform, it has led the national program to reduce the cost of treating this patient, because there is no need now to send the team to provide on-site mentorship, but also there is no need now to refer the patient from the peripheral hospital to bring them to Kibongoto. So now I will share some of the experience. Now the method which we have been using is a retrospective start, whereby we provide a weekly session, a video teleconferencing weekly session every Tuesday for 1 hour, around 14 to 15 hours every week. And where this virtual community of practice approach, it provides a platform for case presentation, whereby we as a hub here at Kibongoto, we provide a room for case presentation, discussion, but also we provide a recommendation for case presentation. But also in every Tuesday, we have a didactic presentation where we prepared around 42 topics to cover throughout the year, and we cover one topic every week. So in 2017, we used this MDRTB Echo platform through case presentation and didactic presentation. So now you can see that using this MDRTB Echo platform, we have reduced by almost 35% the cost of conducting a court review meeting, but also we have reduced. We have conducted this meeting. If it have been conducted in person, this could have costed around $160,000 USD. But also the cost of conducting on-site mentorship, where you send a team of pharmacists, doctor nurses, community health care workers, doctors to provide on-site mentorship. But since we have been providing a virtual on-site mentorship, now we have managed now to reduce the cost by almost 95%, whereby 45 patients we have been initiated on treatment without requiring being referred to Kibongot, but also without requiring our national TB program sending a team of experts for providing on-site mentorship. So now what we have recommended this to be, since it has significantly contributed in reducing the cost of treating the MDR-TB here in Tanzania, and this platform has proven a sustainable and cost-effective mode in resource-limited strain like our country. So we have recommended to be adapted in scale-up and in managing other infectious diseases. So currently now we have almost 7 eco clinics in Tanzania. We are using this for certification of a non-lab tester here in Tanzania, but also we have HIV clinical care echo. But in almost 1 month ago, we have started the HIV pediatric echo. So that's all what I can share, some of the few experience what we have gained here in Tanzania through Echo platform. Thank you. Over to you.
Thank you, Dr. Peter. That was an excellent presentation, and it was great to learn that you have more than half cost has come down for the treatment of your patient. So that's a great experience. Do you have any poll questions? Since I don't see any. Okay, so if there are no questions, there's one question that says, were you able to involve the community in your echo clinics?
Okay, thank you. So far, this platform is required. It's a new technology in our country. Currently, we are not yet able to engage directly the community, but we are on our way to initiate maybe a TB community echo to see if it's possible. But maybe in future or by next year, I will come up if we have already engaged. But currently, so far, we are not yet engaged in them.
Thank you, Dr. Peter. Over to you, Dr. Bruce, for the next session.
Thank you, Nita, and thanks to all our presenters, to Peter, to Daria, to John, to Lilith, and to Upasna. Those were great examples of different programs, TB Echo programs being designed and implemented in different contexts. The goal was really to share with all our workshop participants for you to get a sense of the variety of different approaches so you could see both the common threads that run through all these programs, case-based learning, communities of practice, and but also see that they're meeting different needs depending on the issues, that whether they're trying to address MDR-TB in a high burden setting or latent tuberculosis in a low burden setting. So hopefully you got a good sense of a number of excellent programs from around the world. Now we want to shift gears and engage all of you in a crowdsourcing collaborative workshop piece where we've got 7 questions related to designing your own TB Echo program. So we want you to think about, we're assuming you came to this workshop because you wanted to learn more about what the Echo program is and how it's been implemented in different contexts. Now it's your opportunity to think, how might you design your own Echo program? And we want to just help you kind of test drive your thinking here. And so we've got 7 questions. I'm going to go over the first 2, and then Nita Singla will do the next 2, and then Diana Fortune will do the last 3. And everyone's going to be able to answer these questions, and you're all going to see the answers. These are all anonymous. So we just want to remind you, we won't see who's answering the questions, but you'll all see the answers. And we will then share with everyone all the answers that you share with the group. So the first question is, what is the problem or topic you will be addressing in your Echo, which we assume is likely going to be a TB Echo. And the way you can respond is by clicking on the link in the chat that Amy shared. It's a link to a Poll Everywhere poll. All you need to do is click on that. That'll take you to a web browser on your computer or your phone, and then go ahead and type in that. So I'm seeing the first person is shared. They plan to focus on TB infection and preventive treatment. So one person out there is thinking of TB infection. But we'd love to see 50 responses, ideally. There are at least 50 participants out there right now in the audience. Let us know if your application. Enhance latent TB infection treatment in primary care. There's another TB infection. So one thing I'll give you a heads up, we're going to share a link to WhatsApp, and we've created a WhatsApp group for anyone that wants to join it after the workshop so you can communicate with each other. And it looks like at least 2 people want to start latent TB infection echoes, and you could connect with each other on WhatsApp. TB HIV co-infection, contact tracing and adherence. So that would be a new one. There are currently, India has a TB HIV echo, and TB HIV co-infection is covered in a lot of HIV echoes around the world, as well as some TB echoes. Active MDR TB case finding, Drtb management. There's definitely lots of experience with that through different programs. Community engagement, advocacy and communication, Ltbi, drug safety monitoring, and PK studies. TB and comorbidities, HIV, diabetes, etc. That's a good one. TB data monitoring and use. Kenya started a TB data for action echo. Actually, the union was involved in helping start that. And there's some good experience with that, but it'd be great to see more programs in that area. TB lab methods. There are a number of TB lab echoes. In India, there's actually a TB genotyping echo network. whole genome sequencing lab network echo. So the good news is that for many of these topics, there's some experience. And in that sense, I would encourage another encouragement for joining the WhatsApp group when we share that link, and also joining the TB Meta Echo. HIV with TB patients, data quality and management, user-friendly tools for healthcare providers. In Ethiopia, I'm aware of an HIV data quality echo that's been running over the last 1.5 or 2 years, specifically focused on data quality. But and the Kenya TB Data for Action also focuses on TB data quality. Diagnosed Drtb patients, following up if their samples have been sent to the lab. Well, that certainly would be a topic within an echo. TB infection control, airborne infection control. We have been helping WHO for the last 1.5 years with an infection prevention and control webinar series. They're hoping to start in IPC community of practice next year. And there are a number of IPC echoes out there. Mental health of TB patients, definitely a good topic to be covered in most TB echo programs. TB surveillance among key populations. Great. Well, these are all excellent topics. Any comments from any of our panelists about the topics you're seeing shared so far? Engaging the private sector that are working for benefits, management and prevention of childhood TB. Kenya started a pediatric TB echo a number of years ago. No such, let's see, I think strategic partnerships with holistic approach and proper knowledgeable persons, not professionals. They should be the key person, maybe from governments or private, should be encouraged. Well, one thing I can say, a number of programs, a number of HIV programs have included people living with HIV as lived experience experts among their expert panels. And we actually just launched a long COVID echo with colleagues in the San Diego area and are including several patients with long COVID as experts in the lived experience of long COVID. So I agree that that is something TB echo programs could consider, having TB, either former TB patients with expertise as someone with the lived experience of having TB as an expert panelist. I'm curious, Diana or Nita or others, what you think about that idea.
I think it's a good idea. You know, many times we get caught up in the healthcare professional and forget about the patient, and somebody that's actually had TB, you know, really brings a unique perspective that I think we need to remind ourselves of. So I know we did have, when we did our Project Echo here in New Mexico, we did have one of our patients that had TB infection that did do a little video kind of promoting, you know, taking treatment. So that was really encouraging and fun to hear from her.
Any other presenters want to comment on that? Well, maybe I'll just leave it with as I said, an HIV program in the United States has incorporated people living with HIV as experts with the lived experience of HIV in their expert panel for their HIV quality improvement. It's a national ECHO program. And then this recently started long COVID program borrowed that idea, and we're implementing that as, and just had our first session last week, and it was really great having that voice among the other faculty. So good idea. I think we've seen probably all the feedback we're going to get. If anyone has a question, maybe let me just ask the audience. Anyone have a comment or question related to the topics they saw shared on the screen? Feel free to raise your hand, and we'd love to hear from. We're really trying to make this as much like being in person as possible. We want to keep it informal.
Bruce, I would like to say something.
Great, Nita.
Yeah, I just wanted to say that, whenever we want to start a ECHO, the topic that we take should be a doable. Like we want to do many things. We know there are many shortcomings in the program. But when we think of launching a ECHO, we have to see that that thing should be doable. We have to have expertise for that field. And there is a need, there are need for many things actually. So there is always need for doing many things, but we need to start small, gain the confidence of our audience, of the people, and then grow slowly so that we'll be able to sustain it longer.
Thank you, Nita. That's good advice. Anyone else with a comment about choosing a topic, how broad, how narrow to make it? Okay, let's move on to the second question. So again, please go to the link to Poll Everywhere in the chat, where you'll be able to type your response to this question. What kind of expertise do you want on your multidisciplinary hub team? So as you think about what kind of experts you want to invite to be part of your faculty, who will be among your subject matter experts, who will you want? Will you want a pulmonologist? Will you want a TB lab expert? Will you want a pharmacist knowledgeable in drug interactions? Will you want a community health worker? Will you want a TB public health nurse? What kinds of faculty representation will you want? So the first response was a clinical pharmacologist. Great idea. We definitely try to have pharmacists on as many of our ECHO programs as we're able to. Multidisciplinary TB team. Great. Infectious disease expert, public health specialist, lab specialist. We've found it's definitely helpful having a laboratorian from the state TB lab participate to be able to interpret TB lab results for clinicians. CHWs who know the language and culture, another great idea. And certainly, John, that you could speak to that, having community health worker, TB techs participate along with doctors and pharmacists and nurses. Clinician expert on TB complication management, epidemiologists, clinicians with experience in using new and novel preventive regimens, nursing case managers. These are all great ideas. ICT expert. In the chat, Aquaba noted geoinformatics expert. That's interesting. Akwaba, do you want to unmute and say, how would a geoinformatics expert fit into the expert panel? What would you have them do? TB survivors, back to our prior discussion, pediatrician, psychosocial experts, great idea. We often will have psychiatrists or psychologists among our faculty, stakeholder approach, nutritionist. That's a great idea. I don't know. Diana, we've certainly had nutritionists as guest presenters. We haven't always had them routinely. Do you wish we could have a nutritionist routinely?
You know, it seems like because so many patients with TB are severely underweight. So, and actually I was the one that put that in there because I thought that was something that I thought would be great to have, you know, and trying to find somebody with that kind of expertise to attend to every session is difficult, but I thought it could be really beneficial because that's another part sometimes that we overlook a little bit is making sure, you know, our patients are getting an adequate diet.
Good idea. Demand generation specialists take a stakeholder approach, researchers, paramedical knowledge staff, as well as who should work for not miss, including TB survivors. These are all great ideas. Any of our panelists want to add any expertise you would recommend that we haven't mentioned yet? Microbiologists. And as I mentioned, in India, they have a whole genome sequencing program and more having laboratorians with expertise in genomics who can interpret those results. Certainly helpful to have them on occasionally. Back to our panelists, any additional recommendations?
Yeah, Dr. Bruce, I would like to suggest that, you know, we should get people who are really good in their field and people want to listen to them, you know, so that would get more people to your sessions. So always have an expert who has a good recognition in their field of work, whether they are from, they could be anybody from the lab or a clinician or whatever. So,
yeah, no, that's a great point. Need to recruiting specialists, particularly who really love to teach and who might be well known to your network if they're the laboratorian everyone calls to get results, if they're the nutritionist everyone calls to ask, or the pharmacist who really knows about TB drug interactions, to recruit those colleagues who you know will love being part of a professional social learning network. That will make it more fun and make people want to join. Back to the incentive part.
Bruce,
yeah, John.
Bruce, I'd like to stress the importance of the role of the pharmacist in these ECHO teams in terms of TB disease and HIV with drug interactions in the co-infected patients. Having pharmacists on hand to give advice on those topics has been really, really critical in our ECHOs here. And also, we have a precedence in our national system in the Indian Health Service of having actual pharmacists be clinician pharmacists who almost do all of the management for hepatitis C And I think that you can, we're trying to train our pharmacists to treat latent tuberculosis also. So you can turn, the primary care doc could turn the case over to the pharmacist once they've been seen once and to carry out the whole treatment. So I really like the recommendation in the chat to include pharmacists.
Great, thanks, John. I totally agree. The pharmacists have been terrific partners, and as you said, in hepatitis C and in trying to give them more of a role in latent TB, et cetera, is terrific. Multi-sectoral and various numbers of partner engagement. Okay, I think we've got a lot of great recommendations here. So I think we'll transition to our third question, and Nita, I'll hand it over to you.
Thank you, Dr. Bruce. So who will be your learning community participants be? So please open your chat, and you need to go back to the sheet and start filling who are going to be your audience, who are going to attend. Yes, it's healthcare providers, medical students, primary care providers, doctors, nurses, midwives, TB patients, community health workers, patient supporters. In the chat, we have promoters.
Nita, that promotores are, it's a Spanish term for a community health worker.
Okay, I'm sorry.
That's good.
Yeah, community health volunteers, researchers. We have TB program managers, family members, community members, patient and healthcare providers, healthcare workers, community health volunteers, patient supporters, mass media representatives. That's very innovative. Medical doctors who are currently practicing in DRTB control, pediatricians, lab scientists, TB coordinators and nurses, survivors of TB. Yeah, we call them TB champions here, and we have a separate echo for them where we are, training them to train the community. Counselors, TB clinicians, TB specialists, MDR doctors, healthcare workers, prison hospital medical staff. I think there are very good suggestions coming up. Clinicians, medical officers at primary healthcare centers, all interested personnel who want to gain knowledge and disperse in the society, school nurses. So pretty much everything is covered, and I think they're very good suggestions. It'll be great to do something for the counselors, TB counselors. So, Dr. Bruce, would you like to add something to this?
I don't have anything specific to add right now. Any of our other presenters? Thoughts on who to consider marketing participation? I think the main point is just that it depends on what is the community you're trying to engage. And yeah, that comes down to the goals of the program as you design it. You know, which patients' outcomes are you trying to improve, in what communities, and then what providers do you need to engage to help improve those outcomes? Daria.
I just wanted to add that I think not forgetting administrators of health centers or clinics is really important for the latent TB infection echoes. You know, a lot of times those folks are also those who are managing billing or visit schedules. And so getting their buy-in can actually really help clinicians. And a lot of times they have a different perspective of flow, you know, in terms of how patients are flowing through the health center and accessing care. So that's been really helpful to have non-medical folks involved too.
Yeah, that's a very good suggestion, Delia. So making, once we know who our community of participants is going to be, we need to work out as to how to reach them, because they should be a community to whom we are able to reach and get them on board. So how are we going to contact them? How are we going to, you know, how are they going to use the knowledge that you are going to give them? So all that needs to be planned when you are, you know, calling people to attend your echo. So some very good suggestions have come up in this. I think we can go to the next question now. What do you want your learning participants to be able to do in 1 year that they cannot do now? So we need to go back to our chat section and open the worksheet. This also means that we need to, you know, plan our 1 year. Once we have decided what echo we want to do, who are going to be our experts, who are going to be our audience, who's going to attend this, then we have to have an agenda for at least next 6 months to 1 year, how we are going to cover those topics to do the capacity building, how are we going to strengthen them, and then we need to work out at the end of 1 year whether we were able to achieve what we wanted to do. So the answers have started coming. Contact tracing by 100%. Confidently provide TBT to eligible contacts, TB preventive treatment. Generalists and therapeutists detect TB at primary healthcare facility as early as possible. DRTB management in upcoming decentralized sites. Manage TB patients in a timely manner. Mass awareness campaigns and capacity building. Increase their knowledge of impact of SOC determinants of, of health in TB prevention and control. Design multi-level interventions that address. Can you tell me the full form of these, because we don't use these short forms here? Dr. Bruce, can you help me with that if you are aware of these terms? Okay, yeah, social determinants of health. Provision of DRTB services as part of basic services of the primary care facilities. Set standards of quality care for TB and DRTB patients. Manage the MDR-TB adverse event appropriately. In the chat, we have designed a holistic program to guide about all aspects from diagnostic, treatment, complications of TB. Manage the MDR-TB adverse event appropriately. Tracking of loss to follow-up, drug sensitive and DRTB, and engaging the community to support us. So basically, we should be able to evaluate at the end of 1 year, what have we achieved and how are we going to expand it further? How are we going to, get more people on board to create more hubs or to uh, participate and, disseminate the knowledge. In the chat, we have urban health needs to be addressed aggressively along with POC approach.
So, Dr. Neeta, can I make a comment?
Sure.
So what I've been observing from the past 3 questions is like there are so many issues within TB that on which echoes can be designed as far as topics are concerned, as far as stakeholders are concerned, and as far as attendees are concerned or the spokes are concerned. So it seems that we have a diverse audience and everybody can find a topic or a audience for which they can do a TB echo.
Yeah, you very rightly said that, Upasna. There is so much scope to do so much on echo. We just need to, start and put in an effort. And it generally is a very successful effort once you have a good team and good experts with you.
And there are so many areas which have unmet training needs, in which we need to have a community that I think everybody can find an echo clinic that they could run and manage probably.
Yeah, you very right, Upasna. Thank you. So with this, we go to our next question and over to you, Dinah.
Okay, thank you. So we have just a few more questions to run through here, so everybody hang in with us. Once you've kind of determined who your audience is and who your participants, how will you measure success for your ECHO program? That's one that's a little bit more nebulous and hard to get to, but it does help to have a measure. And I know Daria in her talk talked about doing qualitative evaluations. So sometimes that can be a good indicator by doing interviews of some of your key participants, just to help get your thought processes rolling there maybe. Certainly evaluation indicators. And if you can think before you start your program what success will look like, sometimes that makes it easier to evaluate yourself along the way so you can see if you're actually obtaining that. Participant satisfaction, key informant interviews, yes. Proper outcomes. Using baseline data, and then you can measure success or failure from the baseline data. Reduce loss to follow-up, that's a very clear way. Are you increasing the number of patients that are completing treatment? Improvement of healthcare and case findings. And then in the chat, improvement in notification. Yes, sometimes, just being notified of the patients that have TB in your community, that is a success, so you can ensure complete treatment. Patient satisfaction. So as you're working on your program, you might really think about, how can you narrowly determine what success is? Sometimes it's hard, if you just think, oh, we want to have an increased treatment. Can you narrow that down a little bit and decide exactly what that would look like? So as you're setting out to start your program, you can have that kind of in your back pocket. Influence national and local programs. Okay, so go ahead and continue to think about that. And while you're thinking about that, we're going to go to the next question. And this is always a good one. I think we all can usually think of challenges that we might expect to encounter. And maybe as you're thinking of what challenges you might encounter, be thinking of maybe some ways to meet those challenges too. And one thing, a lot of times when I've been planning, you think of the challenges that you're going to encounter, expected ones, but then I think you need to be ready to pivot and expect those unexpected challenges. Something is going to crop up that you never even thought about. So be willing to pay attention to those different things that might come up. Sustainability, definitely a challenge. A lot of times it's easy to start something, very difficult to keep it going and keep people energized. Persistent challenge, structural and systemic racism. Zoom fatigue. Yes, that's very real. You know, back when everybody started our echoes back in 2015, nobody had heard of Zoom. And now it's like, you know, everybody knows about Zoom. So you do have to deal with that. Before, people didn't want to participate and turn their cameras on because they didn't know how. Now they don't want to turn their cameras on because they're tired of being on video. So that's very real. So you do have to think about that as you're planning your echo clinics to address that. Sustainability in the pandemic, absolutely. Internet connectivity, I think that is key. I think we've heard from several people. We know even in, you know, countries that supposedly are very well developed, we still have huge pockets where we don't have good internet connection. Time management. People that are not familiar with echo. Yes, we can't assume that everybody is familiar with it. Make sure we educate them. Ensuring adult learning procedures. Yes, I think that's very important. Keeping your echo so that adult learners learn in a productive way. That's key. So, okay. So I think everybody is definitely not at a shortage for recognizing challenges. It's kind of thinking how to overcome those. And that is, you know, just to kind of maybe promote the WhatsApp list that we have started. You know, if you have some challenges, you could always put that on there. And I'm sure somebody has probably had a particular challenge that you may be experiencing and could give you some ideas on how maybe they addressed it that you might not have thought of. So that's another way that you can keep our group engaged if you have questions. So, and okay, Amy, if you want to go ahead and go to the next question. I think the next one may be our final one. And this is, when do you hope to launch your ECHO program? So hopefully you've learned a lot today, heard about how it's done in other countries and thought about the challenges and your target audience. So do you have a launch date? And go ahead, you can shoot, you know, what is it? Shoot for the sky, you know? There we go, early 2022. Yes, it's amazing that it's going to be 2022. Oh, somebody's already launched their ECHO, so they're doing good. So those of you that have already launched one ECHO, is there something different that you have, a different target audience that you may want to address in a different ECHO? So this is one probably some people may be a little reluctant because you don't want to kind of give yourself a date and then you might not make it. So may be reluctant to put it out there on the chat. So I believe that is our last poll question, right, Amy? Is there any after that? Yep, all done. So, okay. And go ahead, you can continue to put your comments in there. So thank you all for answering all these polling questions, and hopefully this helped to stimulate some thought in your mind as you're planning your ECHO session, or if you already have an ECHO, maybe you've gotten some new ideas and different techniques that you can use for your particular ECHO that you do. So Bruce, I'm going to hand it back to you for the next steps.
Thanks, Diana. One thing, since I shared the link to the WhatsApp group that we'll use for anyone who wants to continue the conversation after this workshop, if you scan this QR code, which I'm sharing on the screen, that'll allow you to quickly join the WhatsApp group. Otherwise, we'll share the link in the chat. We'll just leave it there for a second or two. We'll bring it back up maybe at the end. But just want to thank all our participants for taking 3 hours out to join us today. There were about 60, 70 people that joined live, and about 400 people had registered, and they will all have a link to the recording shared with them so they can watch this at their own timing. And then really want to thank again our presenters and our chairs, Nita and Diana, John, Daria, Upasna, Peter, Lilith. I love hearing these presentations. So one of the things that really motivates me to, and Amy together to propose these sessions is that we get to work with fabulous colleagues to prepare for the workshop. And I really love hearing the updates from our colleagues because it's inspiring to hear all the great work. And hopefully many of you were also inspired. And the next step really is for those who haven't yet started an ECHO program to become a partner and attend immersion. And as I said earlier, there's no cost to being a partner and there's no cost for the immersion training, which are now all virtual. And we do them every month in New Mexico on US time. And we're actually doing them every other month for Africa and Europe. And our team in India does them almost every month, if not more, in India for the Asia time zone. So I thought, we heard a lot of great presentations. It was the most fun, though, also is hearing from you all. And thanks for participating in the Poll Everywhere crowdsourcing. Hopefully, we look forward to hearing whether you liked this approach. It's challenging to engage 50, 60, 70 or more people and make sure everyone gets an opportunity to contribute. That was the idea of using the Poll Everywhere, so everyone could share their ideas with all the other participants. And as I said, we will share a copy of the transcript of what you all wrote. So you'll see how everyone answered those questions. We have a couple of minutes. Does anyone have any questions for our panelists before we've got about 8 minutes before we wrap up? And also from any of our panelists, any comments you'd like to make, questions or comments you'd like to share? Aziz, please go ahead.
Yes, thank you very much for the nice presentation. All colleagues presented. Just I have a question from Armenia colleagues. I think she's available now or not. Lilith.
Yes, she's here.
She presented a nice presentation about the ecosystem that they started on July 2021. Actually, it is not a mature program right now because it's almost 6 months that they launched the program. But the loss to follow-up of Drtb patients was very high. It was 26%. And I think the successfully completed Drtb was only 44%. In this case, while they are using the ecosystem, she said that most of the patients are seeking the jobs outside of the Armenia, especially to the Russia. And the Russia has also the strong Drtb program right now, and the neighboring country of Armenia as well. If they establish a strong referral system between neighboring countries that WHO suggested about cross-border TB patients, it would decrease the number of lost follow-up patients and increase the treatment successfully DRTB patients in the future. This is my idea. If she would like to respond to this, most welcome. Thank you very much.
Thank you, Aziz. Lilith?
Thank you so much, Aziz, for your comment. Indeed, we have a big problem with this seasonal migrants with their treatment monitoring, follow-up, and loss to follow-up. But currently, unfortunately, we don't have any cross-border or interinstitutional or intergovernmental agreements between our countries on this respect. But we have started the negotiations a few months ago, and we hope that we'll come to an agreement for all these people who live to earn living in other countries to have alternative options, either paying the host countries for their treatment in order to make them not to interrupt their treatment, or allow them take their medications with them, their drugs with them, and to be followed up by the local primary healthcare facilities. So we are now working on this, and we hope that we will have a great success on this. Thank you very much.
Great, thank you, Lilith. Wandwosen, please go ahead. Wandwosen, you've got your, go ahead.
Okay, thank you. Just my concern is about this loss of follow-up or discontinuing of treatments, TB treatments due to disasters or war, like some countries in Ethiopia. Because of this reason, how to manage patients, the way how to provide drugs, especially this discontinue become in between conflicts from countries to countries. Is there any possibility of managing this discontinue?
Well, thanks for that great question. I may defer to colleagues who may have a good idea about that. I think one way that ECHO can be helpful in conflict situations, and there's a recent ECHO started in Sudan that has been very successful, and in South Sudan as well, that have been a way when it's insecure and difficult to travel, that people have still been able to communicate and to find solutions to problems like the one you're describing of how do we collaboratively find solutions to get drugs to our patients when there's insecurity. So the ECHO itself may not deliver the drugs, but it can deliver ideas and shared experience from colleagues who have figured out ways to get drugs to patients. So I think that's where ECHO can be helpful. Do any of my colleagues have ideas on that they might want to share? Great. I know, Lilith, I mean, you were in a conflict situation last year, and I don't know how you've managed or how the ECHO has been helpful during the conflict or post-conflict.
Unfortunately, we didn't manage to use ECHO program while we were in the middle of the war. It was not a priority at that time, and I have no comment on this.
Okay, thanks, Lilith. One thing I will also just draw attention to the chat, and Mariana Bujashvili, who runs the ECHO program in Georgia, has a number of comments she'd like to share there, but she has to take off. So thanks, Mari, for sharing those.
Thanks, Bruce. I would also jump in here. Thank you,
Great.
everyone, for amazing presentations. It was really interesting and impressive to listen to colleagues' development and the development of their ECHO projects. And we are also happy to be part of ECHO community for over 5 years. And we are mainly focusing for now on the clinical part of TB, but I really do hope to expand our directions in the future. So thank you very much for this opportunity, and thanks for having us here.
Thanks, Mari. Take care. So I know we're at the almost top of the hour. I know our union colleagues want to say a word about the survey and the certificate of attendance.
Yes, thank you. Thank you, Bruce. Thank you, everyone, for attending today's postgraduate course. Once the Zoom meeting will close, you will see the survey appear directly in your browser. It will pop up directly. We would appreciate if you could complete it and provide your feedback. It's important that you complete the survey right after the workshop because the link will not be active for a very long time. You will receive a follow-up email within the next 24 to 48 hours with a link to view the recording of today's postgraduate course. And you also should be receiving a certificate based on your attendance and also if you complete the survey within the next 2 to 3 days. On behalf of the union and our presenters, thank you for joining us today and enjoy the rest of your day. Thank you very much.
Thank you, Carolyn. Thanks, everyone, for joining. Thanks, Nita and Diana, for the great. Thanks, everyone. Be well. Take care.
Yeah, thank you, Union. Thank you, Dr. Bruce. Thank you, Diana, and thank you, all the speakers.
Bye.
Thank you.
Yeah, thank you, all the participants.
Thank you.